Good morning. I am Dr. Leena, Assistant Professor in the Department of Ophthalmology at Sri Lakshmi Narayana Institute of Medical Sciences at Puducherry. Today I am going to discuss about the topic primary open angle glaucoma and primary angle closure glaucoma. What is glaucoma? Glaucoma is defined as a chronic progressive optic neuropathy with optic nerve head changes and characteristic visual field changes with IOP as the only modifiable risk factor. Here is a picture where it is depicted as there will be a blockage in the drainage canal which causes accumulation of too much fluid in the eye, which further causes increase in the pressure, which further damages the optic nerve. Glaucoma is broadly classified into three main types: open angle glaucoma, angle closure glaucoma, and childhood and developmental glaucomas. Open angle and angle closure glaucomas are further classified into primary and secondary types. Childhood glaucomas, we are dividing it into three main types: congenital glaucoma, where the glaucoma which is happening up to the 1 month of age group is called as congenital glaucoma. From 1 month to 3 years of age group, we are dividing it into infantile glaucomas. From 3 years to 13 years, we are dividing it into juvenile glaucomas. After that, everything comes under primary open angle glaucomas. Okay, now I'm going to discuss about open angle glaucoma. In this picture, we can see the angle, anterior chamber angle is open, where the trabecular meshwork is getting blocked, so that the fluid gets accumulated in the anterior chamber, which further causes pressure in the eye. Increased pressure in the eye, which will cause damage to the optic nerve. So, primary open angle glaucoma is also known as chronic simple glaucoma, which is a bilateral chronic progressive optic neuropathy, and it is the most prevalent glaucoma which affects both sexes equally. Here, the IOP will be more than 21 mm mercury, and definitely there will be a glaucomatous optic nerve damage. The angle is always open here, and the patient will have characteristic visual field loss also, and there will be no signs of secondary glaucoma or non-glaucomatous cause for optic neuropathy. When we see epidemiology, it affects about 1 in 100 population of both sexes above 40 years of age group. Okay. Risk factors. Who will get primary open angle glaucoma? So, increasing age group, increasing IOP, and myopia patients are having a slightly more risk factor than others. Family history is always positive, and not always positive, maybe positive. In past history, we can get asthma, heart block patients, and diabetes mellitus patients will have more risk than other patients. OCP usage and steroid usage also contributes to primary open angle glaucoma. Okay. How there will be a rise in IOP in open angle glaucoma. So, here the angle of the anterior chamber will always be open, and what happens here is the trabecular meshwork might undergo some thickening and sclerosis with faulty collagen tissues, and narrowing of the intertrabecular spaces can also lead to increase in IOP, or some other deposition of amorphous material can happen in the juxtacanalicular space. Otherwise, collapse of the Schlemm's canal and absence of giant vacuoles lining it can also lead to closure of the angle. All these might contribute to the pathogenesis of increased IOP. Okay, next one is pathogenesis of glaucomatous optic neuropathy. There are two main theories: ischemic theory and mechanical theory. Ischemic theory states that raised IOP will cause the poor perfusion of optic nerve head, which further leads to loss of retinal nerve fiber. Next one is the mechanical theory. Mechanical theory explains that direct compression of the retinal ganglion cells due to raised IOP will lead to the death of retinal ganglion cells. Next, pathway is common pathway, where both factors, ischemic and mechanical theory, both will contribute to the damage of optic nerve. Clinical features. How the patient with open angle glaucoma have vision is depicted in this picture. They are usually asymptomatic, and gradually painless loss of vision can happen. Headache, eye pain, visual field defect, and frequent change of presbyopic glasses, delayed dark adaptation, all the symptoms of primary open angle glaucoma patients. Examination, we have to check the visual acuity. IOP must be more than 21 mercury. Next one is diurnal variation test, where we have to observe the patient for every 3 to 4 hours for the first 24 hours. Um, Most of the patients will have biphasic rise. 55% of the case will have biphasic rise. Otherwise, 20% will have morning rise in IOP, 25% will have afternoon rise in IOP, and we have to compare both eyes. If there is any asymmetry of IOP more than 5 mercury, um, then we'll call the patient as open angle glaucoma patient. What is tonometry? IOP is always measured with an instrument called tonometry. We have two main types of tonometry: indentation and applanation tonometry. Here, I have divided tonometry into direct and indirect tonometry. Direct is an invasive procedure. Indirect is non-invasive. Indirect is further classified into non-contact, which is Short's tonometry. Next one is contact. Contact is further divided into indentation and applanation tonometry. Indentation tonometry is Short's. Then third one is palpation method. In applanation tonometry, we have two types: variable force and variable area. Variable area is McClurkoff. Variable force, Goldman applanation tonometry, Perkins, Dragers, McKemar, Tonopen, and pneumotonometer. This is the picture depicting Short's tonometry. This Short's tonometry will have a measuring scale, a needle, and weights like 10 and 7.5 are indicating weights. Then lever arm is there and plunger below which is holder. Um, After that, a barrel is there and foot plate, and um, foot plate will rest over the cornea of the eye. This is how we have to check the short tonometry. The patient must be made to lie down, and cornea is anesthetized with proparacaine. After that, we have to place the short tonometry vertically over the cornea of the eye, and we have to indent. So it comes under indentation tonometry. Next one is the technique of applanation tonometry, which we most commonly use is Goldman's applanation tonometry. Here, the patient is made to sit under slit lamp, and there will be a Goldman applanation tonometry apparatus will be there. With the help of that, we are going to measure the IOP. First, we have to make sure that patient should not move their eyes while recording the IOP. Here, the patient is anesthetized with the proparacaine eye drops. Then we have to instill fluorescent dye into the eye. Then, with the help of cobalt blue filter, we have to focus the cat prism. The cat prism is made to come in front of the patient's eye, and it is moved forward. There will be graded readings will be there. That knob we have to rotate till we see Myers. So before we have to bring the Myers together. The next picture will show how the Myers will be seen. There will be two semicircles. The two semicircles will have an inner circle and an outer circle. We have to bring two inner circles together. In the picture C, we can see how the two Myers are brought together. This marks the picture C marks the end point, and by rotating the knobs, we can measure the IOP. Below one is Perkins handheld applanation tonometry. Here also we get the similar picture as CAT. It is mostly used for children, uncooperative patients, and psychiatric patients. What are the investigations we are going to do in POAG? First, we have to do clinical examination. Pupillary reaction will be sluggish, or RAPD will be there. In slit lamp biomicroscopy, we have to rule out other secondary glaucomas like pigmentary and pseudoexfoliatory glaucomas. Then gonioscopy to look for the angles. Then optic disc examination. Then comes the pachymetry, which measures the central corneal thickness. Then comes the perimetry and OCT imaging. And for POAG, we have a provocative test, which is water drinking test. What is gonioscopy? Gonioscopy is the technique of a biomicroscopic examination of the angle of anterior chamber. We have to measure it using a special gonio lens. The angle structures are seen from behind forward, uh, uh, which are further classified into four main structures: ciliary body band, scleral spur, trabecular meshwork, and Schwalbe's line. So this is how we get a picture in while looking through a gonio lens. So below dark one is a ciliary body band. Next to white thing is scleral spur. Next to dark one is trabecular meshwork. In trabecular meshwork, we have posterior pigmented and anterior non-pigmented trabecular meshwork. Then after trabecular meshwork, we have a thin gray line which shows Schwalbe's line. Next one is manual perimetry. Manual perimetry, we have four types. Confrontation method. Confrontation is by making the patient sit in front of the examiner. Uh, by moving our hands, we can measure. We can identify the visual field. That is confrontation. Next one is the Lister's perimeter, and Campimetry is there, and Coleman's perimetry is there. Now, latest technique is by measuring through automated perimetry. Automated perimeters are always computer assisted, and they test our visual field by a static method. So, commonly used automated perimeters are Octopus Field Master and Humphrey Field Analyzer. Next, we have to moving on to optic nerve head evaluation. Normal optic nerve head has a distinct disc margins, pink in color, and vessels will be arising from the center. And neuroretinal rim is the tissue between the outer edge of cup and the disc margin. Always the neuroretinal rim is pink in color. Cup disc ratio is normally 0.3 to 0.4. So what happens in POAG is in advanced cases, we have market cupping, that is cup disc ratio 0.7 to 0.9, and there will be thinning of neuroretinal rim, and nasalization of retinal vessels will be there. Then we'll get bionetting sign. What is bionetting sign is the vessels will have a sharp angulation when they enter the optic nerve. That is, the vessels will be reaching the optic nerve at 90 degrees, more or less 90 degrees. Next is a lamina dot sign, where we can see some pores in the optic nerve. Due to the thinning of the neuroretinal rim and ganglion cell loss, we can see some black dots, which indicates pores. That is lambda dot sign. Next one is the glaucomatous optic atrophy. It is the end stage where all the neural tissues will be destroyed and optic nerve head will appear white and deeply excavated. In early changes, we can see vertically oval cup, and there will be asymmetry of more than 0.2 between the two eyes. And otherwise, in one eye, we can get a large cup disc ratio of 0.6 or more, and there will be pallor of optic disc also, and splinter hemorrhages. Splinter hemorrhages are like they appear like flame-shaped hemorrhages around the disc. These are some non-specific signs of glaucomatous damage. First one will indicate inferior bearing of circumlinear blood vessels. In picture B, we can see bionetting sign, and C will show collaterals. And in D, we can see loss of temporal neuroretinal rim. And in E, we can see that lamina dot sign, and in E, we can see a splinter hemorrhage at the infratemporal part of the disc. What are the visual fields we are getting in POAG? The earliest visual field defect we are going to get is isopta contraction. Next one is bearing of blind spot. And next one is paracentral scotomas, then serial scotomas, then arcuate scotomas, and ring or double arcuate scotomas, then Roney's central nasal step. And next one is the, at last we'll get an island of vision, temporal island of vision. Next comes the treatment part. Um, in treatment, we have medical treatment, laser treatment, and surgical treatment. medical treatment, we have all the drugs. The drugs will have three main actions, like drugs decreasing the aqueous production. In this group, we are having alpha agonists, beta blockers, and carbonic anhydrase inhibitors. Next one is the drugs which increases trabecular outflow. Here we have myotics and rho kinase inhibitors. Next group is drugs which increase severe scleral outflow. Here we have prostaglandins. First, we are going to see about beta blockers. The mode of action is they block the beta receptors in the ciliary processes, thus leading to decreased aqueous production. They are used as first-line therapy, and we are having the preparation as timolol, bitoxolol, lipobunolol, and cartiolol. Um, the main side effects are arrhythmias, heart failure, bradycardias, bronchospasm in asthmatics, and SPKs means superficial punctate keratitis and corneal anesthesia. Um, the um, the main thing is they are contraindicated in asthma, COPD, heart blocks, and congestive cardiac failure. And next comes the adrenergic agonist. Their mode of action is by increasing the aqueous outflow by acting on both alpha and beta receptors. Um, they cause uh, we have the preparation as epinephrine, dipivefrin, apraclonidine, brimonidine. They have their own side effects like eyelid retraction, lid edema, dermatitis, allergy, mydriasis, and cystoid macular edema in FAKs. Uh, Next group is carbonic anhydrase inhibitors. Their mode of action is by decreased aqueous humor production. They are indicated as a short-term therapy in acute cases. Um, they are divided into oral and topical varieties. Oral one is astazolamide and topical one is brinzolamide and dorzolamide. Side effects will cause induced myopia, stinging sensation, keratitis, and Steven Johnson syndrome is the most expected side effect. Next one is parasympathomimetics. They will cause increased trabecular outflow. They are also known as myotics. What are the drugs available in myotics are pilocarpine. Most common is pilocarpine. Their side effects include increased salivation, diarrhea, sweating, abdominal cramps, meiosis, and meiosis will further lead to myopia and retinal detachment. Next, most common drug we are using is prostaglandin analogs. Their mode of action is by increasing the evioscleral outflow. Um, the drugs available here are latanoprost, bimatoprost, and travoprost. Side effects include conjunctival hyperemia, eyelash lengthening, hyperpigmentation, iris hyperpigmentation, and anterior uveitis and cystoid macular edema. Next one is the hyperosmotic agents. Um, Hyperosmotic agents, they act by increasing the plasma tonicity and by dehydrating the vitreous, they will reduce the IOP. They are used to control the acute episode of elevated IOP. Um, the main agent we have in hyperosmotic agent is 20% mannitol and oral glycerol, 50% oral glycerol. The side effect is they should be cautiously used in hypertensives, and oral glycerol should be cautiously used in diabetics. Next comes the treatment approach. In treatment approach, first we have to record the baseline data and we have to grade the severity of glaucoma. Then we have to identify the target IOP. Then we can initiate medical therapy. Baseline data includes examination also. So first we have to check the visual acuity, slit lamp examination of anti-segment. Then we have to measure the IOP by applanation tonometry. Then central corneal thickness measurement by pachymetry. Next comes the optic disc evaluation, gonioscopy, and visual field charting. Then we have to grade the level of glaucoma damage. How we are grading the glaucoma damage is mild one is mild patients will have optic nerve head abnormalities with normal visual field. Moderate glaucomatous damage is characterized by visual field abnormalities in one hemifield, not within 5 degrees of fixation. Severe varieties are visual field abnormalities in both hemifields. and within 5-degree fixation. Next, we have to set our target pressure. After how we are going to set the target pressure is we have to measure the baseline IOP, and then we have to check the level of damage, and we have to reduce the baseline IOP. For mild damage, we can reduce 30%. For advanced damage, 40% reduction. Ocular hypertension cases, 20% reduction. Normotensive glaucoma, 30% reduction. First, we have to go with monotherapy. Either we can start with beta blockers or prostaglandins. Then we have to check the tolerability by measuring the IOP. When the target IOP is reached, we have to continue the monotherapy. And even after the continuation, we have to again check the target IOP. When it is maintained, we have to periodically check our optic disc and visual field examination. If the target AOP is not reached by after monotherapy, we have to add one more drug. The second drug we have to add, and after that, again we have to measure the target IOP. If the target IOP is reached, we can go with periodical examination. If the target IOP is not reached, again we have to substitute the second drug. And after substituting, we have to check the efficacy and tolerability. Again, if it is not controlled, we can go for other options like surgery and laser. Okay. Lasers and POAG. We have two functions in lasers. For outflow enhancement, we have laser trabeculoplasty. For inflow reduction and cyclophotocoagulation. Surgery in POAG. Indications: failure of medical therapy, progressive damage, or high intraocular pressure. And we can combine with cataract procedure also. What are the types? Penetrating filtration surgery, we have trabeculectomy. Non-penetrating filtration surgery, we have deep sclerectomy and viscocanalostomy. What happens in trabeculectomy is we have to create a fistula between the angle of anterior chamber and subtenon space, which will allow the aqueous to flow from anterior chamber to drainage plug. The procedure involves conjunctival flap creation, partial thickness scleral flap creation, and excision of trabecular tissue. Peripheral iridectomy has to be done. Then we have to close with monofilament suture. What are the complications of trabeculectomy? Post-op shallow AC, hyphema, iritis, cataract due to accidental injury to lens, endophthalmitis. Next, moving on to angle closure glaucoma. What causes angle closure is iridotrabecular apposition or adhesion, which will further leads to obstruction to the aqueous outflow, leading to raised intraocular pressure. Here is a picture where we can see how the angle is getting occluded. There is anterior bowing of iris, which further occluded trabecular meshwork and leading to angle closure. So due to the angle closure, the pressure builds up in the eye and which causes the damage to the optic nerve head. There are three stages: primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. In PACS patients, we can see only angle closure will be there, and IOP will be normal, and optic nerve head will be normal. Visual field will be normal. In PAC, we have angle closure will be there, increased IOP will be there, but with normal visual fields and normal optic nerve head. Next comes the primary angle closure glaucoma. Here we have angle closure with raised IOP with abnormal visual fields, and optic nerve head changes will be there. So again, primary angle closure suspect, we have normal IOP, optic disc, and visual fields, and no peripheral anterior synecdoche. And in gonioscopy, they'll be showing posterior iridotrabecular contact. Here there is a risk of getting PACG at 5 years, maybe around 30%. Next comes the primary angle closure. Here we have normal optic disc and field, but raised IOP will be there, and gonioscopy will have 3 or more quadrants of iridotrabecular contact. Next one is the primary angle closure glaucoma. Here, primary angle closure changes with the glaucomatous optic nerve head changes will be there. Iridotrabecular contact in 3 or more quadrants with glaucomatous optic atrophy can happen. Optic nerve damage will be resulting from severe IOP elevation. So, what are the damages we are going to get in primary angle closure? So, in primary angle closure, we can get iris atrophy, endothelial cell loss in the cornea, and trabecular damage or peripheral anterior synechiae can be there. And we can get lens damage also. If the IOP is too much high, we can get glaucomatous optic neuropathy. Then we'll have ischemic optic neuropathy also. Um, Next one is the relative pupillary block. In relative pupillary block, there will be failure of aqueous flow through the mid-dilated pupil, which leads to a difference in the pressure between the anterior and posterior chamber with resultant anterior iris bowing, which is called as iris bombay, which blocks the trabecular meshwork. Non-pupillary block relating to iris-specific anatomic factors, which will include plateau iris, plateau iris configuration and plateau iris syndrome is there. In plateau iris configuration is characterized by a flat central iris plane in association with a normal central anterior chamber depth. In plateau iris syndrome, there will be occurrence of angle closure despite a patent iridotomy in a patient with a morphologically bad plateau iris. Next comes the lens-induced angle closure. Here there will be sudden change in the lens volume. So in intumescent lens, we can get phygomorphic glaucoma, or if there is any change in the lens position like anterior lens subluxation, we can get angle closure. Next one is the retrolenticular causes, which includes malignant glaucoma or any posterior segment causes of angle closure, which is known as secondary angle closure glaucoma. Next one is the combined mechanism. In combined mechanism, we have both components of angle closure and open angle components. What causes reduction in the aqueous outflow is due to the oppositional obstruction by the iris or any degeneration of the trabecular meshwork, or if there is any permanent occlusion of trabecular meshwork by peripheral anterior synechiae. This picture indicates the mechanism of angle closure. First one is the relative pupillary block. There is a pupil block and accumulation of fluid behind the iris will be there, which further causes iris bombay. Next picture depicts how iridocorneal contact occurs and closure of trabecular meshwork occurs. Risk factors in PACG includes age more than 40 years and Asian people, women, family history. In hypermetropia, we can get, and if the patient has shorter axial length, we have risk of getting PACG. Symptoms include blurred vision, colored halos due to corneal edema, headache, eye pain, nausea, vomiting. And the precipitating factors will be like if they watch TV in dark room, or if we dilate the patient with mydriatics, and emotional stress will also further leads to primary angle closure glaucoma. Signs include first, we have to check the visual acuity. Here, the vision will be ranging from 660 to hand movements. IOP will be high. It can go up above 40 millimeter mercury. Conjunctiva will have circumcorneal congestion. Corneal edema will be there. Shallow anterior chamber, and in AC we can see flare also. Pupil will be non-reactive, mid-dilated pupil. The first picture shows how the anterior chamber looks in PACG. Next one is showing numerous epithelial cyst in the cornea. Next one shows how the pupil in acute angle closure attack will have this mid-dilated vertically oval pupil. So in chronic presentation, visual acuity is normal. IOP is elevated intermittently. AC is shallow. Creeping angle closure is characterized by gradual band-like anterior advancement of an apparent insertion of the iris, which starts in the deepest part of the angle and spreads circumferentially. Episodically, intermittent iridotrabecular contact is associated with the formation of discrete PAS, Individual lesions have pyramidal sawtooth appearance, disc cupping with or without visual field effects. The signs of chronic angle closure glaucoma, it is similar to POAG with cupping and visual field loss will be there, and they are easily missed unless we perform gonio, and there will be variable amount of angle closure only. What is resolved or post-congestive angle closure glaucoma look like? There will be folds in the descemet membrane if the IOP has reduced rapidly, and optic nerve head congestion will be there, and choroidal folds will be there. Vox triad include iris atrophy, irregular pupil, posterior synechiae, and glaucoma flecken. Iris torsion is there. So these pictures depict how resolved angle closure glaucoma look like. First one indicates stromal corneal edema and folds in the descemet membrane. In picture B, we can see glaucoma flecken. Uh, in picture C, we can see how the optic atrophy has set in. Here also in investigations, we have to measure the anterior chamber depth and gonioscopy and anterior segment OCT, posterior segment also we have to look for, and any causes of secondary angle closure or malignant glaucoma. Posterior segment examination by B scan should be done. This picture indicates plateau iris configuration where there is loss of ciliary sulcus due to anteriorly located ciliary processes. Next one is the gonioscopy showing total angle closure. Next, below which we can see open angle after giving laser iridotomy. The provocative test includes pharmacological and paraphysiological test. For pharmacological test, we have to do um, pupillary block mechanism in a mid-dilated state, which causes increased tension of iris by instilling short-acting mydriatics. The test will prove positive uh, so that acute attack may be triggered with if we put a mydriatic in an angle closure patient. Next one is the paraphysiological test. We have a dark room prone test. The physiology behind is in dark, the pupils will dilate and the lens will move forward in prone position. So this will also further, it can trigger angle closure. So how we are going to do this is patient is made to be sit in dark for 30 minutes with head in prone position, and the patient should not sleep, and IOP has to be checked. The test is rapidly positive if there is a IOP increased by 8 mm mercury. What are the differential diagnosis? Lens-induced angle closure, malignant glaucoma, any other causes of secondary angle closure, neovascular glaucoma, hypertensive uveitis, scleritis, pigment dispersion, pseudoexfoliation, and orbital or retroorbital lesions. How a PACG attack can be managed is immediately after attack, we have to check the IOP. If the IOP is below 30 mm mercury, we can give pilocarpine drops. If it is more than 30 mm mercury, pilocarpine won't act. So in that case, we have to start on IV mannitol, and we have to perform corneal indentation using a Zeiss 4-mirror lens. After 60 minutes, if the attack is broken, the pupil can be constricted, and IOP can get lower and corneal flaring can occur. In that case, we can start with pilocarpine and topical corticosteroids, and then we can, after getting corneal clearance, we can do laser peripheral iridectomy. For pain, we can give topical ketorolac or any pain medication. If the patient is vomiting, we can give metoclopramide. Otherwise, if the patient is comfortable, we can perform laser peripheral iridectomy in the other eye. If the attack is not broken, we can go for IV osmotic. Uh, IV osmotic, if not already given, we have to check the status of cornea. If the cornea is clear, we can do for go for laser iridectomy. If the attack is not broken, again we can go for surgery. If the cornea is cloudy, we have to give we have to try all the topical and IV measures to reduce IOP. Again, the IOP is not controlled after giving all these things. We can go for laser iridoplasty. If the attack is not broken even after laser, we can go for surgery. How do you perform peripheral laser iridotomy? A hole is made in the iris periphery, allowing the aqueous to drain from posterior chamber to trabecular meshwork. The lens we are using is Abraham lens, which is a plano-convex lens of 55 diopters. Here, the principle is by photo disruption. The laser we are going to use is Nd:Arc laser 1064 nm. The site we are selecting is 11 to 1 o'clock position at the crypts of iris. Before giving laser, we have to instill pilocarpine for 30 minutes and we have to make the iris stretch. After giving laser, we have to give post-op steroids and anti-glaucoma medications. We have to examine the patency and the size of iridotomy after getting laser. How do you perform surgical peripheral iridectomy is by removing the iris tissue using a knife or scissor. 2 to 3 of peripheral corneal incision in the supratemporal site is done, and iris piece is held with the tooth to forceps its fine scissors, and we have to cut it. Next comes the organ laser iridoplasty, which aims to shrink and flatten the iris tissue without um, damage placement of circumferential ring of non-penetrating contraction burns at far iris periphery. Um, Here it will cause evenly spaced application of burns should be given, zero point 0.2 to zero point 0.5 seconds with low power. One more thing is lens extraction can also be done to reduce the IOP. Next comes the trabeculectomy. In trabeculectomy, we can lower the IOP by creating a fistula to allow the aqueous outflow from antechamber to subtenon space. The fistula is protected by a superficial scleral flap. When medical therapies fail to achieve this, in spite of adequate control of IOP, we can go for surgery. This is how a flap is created and the fluid is made to exit through the opening. Thank you.